Well, welcome everyone, and thank you for tuning in. My name is Will Moore. I'm a physician at Farrell Duncan Clinic, Internal Medicine. I've been a physician here for 23 years. This is in Springfield, Missouri. I've taught students for all those 23 years, so I've probably had 200 or so students over that period of time. And I've just recently, I guess recent being the last 5 or 6 years, been doing some lectures for the MU Medical School, which is where I graduated from in Columbia. Lectures for them for the third year medical students on different internal medicine topics. And so this is one of my lectures, which is on evaluation of ascites. And we'll begin, first of all, with a case. And this is a patient that would present to my clinic, 68-year-old male who presents with complaint of stomach swelling. So I like to have interaction with the audience for my lectures. So this is not just me spouting off facts, but I just like kind of what questions would you be thinking about to ask this patient with this stomach swelling? What questions do you want to know?
How long has it been going on?
Good. So definitely want to know chronicity. Has this been going on for months, weeks, or has it only been for the last few days?
Does
What
anything
else?
make it worse, make it better?
Right. So maybe it has to do with eating, not eating.
Any possibilities of pregnancy?
Good. Yep. Part of the differential for sure.
Deep breath.
Alcohol use or IV drug use?
Good, yes. So thinking about like past medical history, what kind of things might be going on in this patient's past? Is there any history of liver problems with it coming up with alcohol use, risk factors for viral hepatitis, all those things that might end up causing end-stage liver disease, since that's one of the definitely high possibilities on your differential in somebody that has ascites. So that's all good. So before we talk about ascites, I want to step back and say what would be the differential diagnosis of someone just with abdominal distension. And again, as we said earlier, the chronicity will make a difference on the distension, whether it's just been a few days or if it's been going on for a longer period of time. Whether abdominal pain is associated with it, that's another big thing that you would ask the patient is, are there other symptoms like abdominal pain, jaundice, things like that that are going on as well. But what would be in your differential just of someone that had a distended abdomen?
Bowel obstructions?
Yes, so that would be definitely more acute. So we would see that that's just happened over a day or two. Usually they have severe pain associated with that. So, and their exam is going to be, that of an acute abdomen with rebound and other things. So that's good. What else?
Bowel perforation.
Right. That's along the same lines as the obstruction. It would be very acute.
Malignancy, pregnancy.
Yes. The other thing too to think about is just obesity in general, because it's extremely hard to differentiate ascites from adipose tissue. And again, since we have kind of an epidemic of obesity, it's made it much more difficult to decide whether there's obesity involved or fluid involved. So that's one also on the differential. This was a patient that I saw. This is a scan of a patient that I saw probably now 6 or 7 years ago, who came to my office with a 6-month history of swelling of the belly. And I did the exam pretty much, felt like there was ascites present, sent them for their initial ultrasound. But the tech called me and said, Dr. Moore, this is not a fluid in the belly. This is a tumor of the belly. So this patient had a cystadenoma of the ovary that had grown to the size of a basketball. So in part of your differential, ovarian tumor would be part of that as well that had grown. And this was a benign tumor, by the way, and was removed by one of our gyn-onc surgeons, and the patient did fine. But that would be in your differential as well. And the bowel obstruction, also the bowel perforation, if it's very acute, would be in the differential.
Dr. Moore, I don't think we're seeing your screen. You're showing us scans.
Yeah.
Yeah, we can see slide 15.
It says that my screen is paused. Is that right?
It
Again-
looks like we can see your, like the presenter view of PowerPoint.
I'm pretty new to this.
Do you have,
Do you have dual monitors?
I do have 2 monitors.
Okay, so I think we're seeing the monitor, maybe the other monitor.
So I can stop sharing and restart.
Mm-hmm.
How about now?
Perfect. We can see a abdominal distension and a scan of some sort.
Yes.
Okay.
And you can see everything moving on the screen then as I kind of scroll through.
Yep.
Okay, good. So I think we're up to date. So that is a scan of a ovarian cystadenoma that was one of my patients that came to me with abdominal distension. Just to know that obviously that's very rare. That's the only case I've had in 23 years, but something that would also be a zebra on your differential for sure. So let's go to causes of ascites, because we've already mentioned some of them from the comments you all have made up to this point. So give me kind of what's your differential if the patient does have true ascites.
Cirrhosis.
So cirrhosis is number 1. In this case study, it was 81% of patients. So that was like, it comes out to about 8 out of 10 patients end up having cirrhosis as a cause of their ascites. So liver disease by far is the most common cause of ascites, but it's not the cause of all ascites. What else?
Heart failure.
Heart failure, yes. I gave away the next one thinking it was heart failure, but heart failure is less than 10%, but it is present. Usually heart failure is more advanced that when it causes ascites, in other words. So it usually has to be stage 4 NYHA criteria. So advanced heart failure then causes accumulation of fluid in the belly to result in ascites. So it's more of an end stage sign of heart failure. So you don't see that very often in patients with heart failure, but it needs to be in your differential. What's the one that I gave away?
Cancer, malignancy.
Ovarian carcinoma.
Very good. So cancer is 10% of the time. So 1 out of 10 can be related to cancer. And yes, you already beat me to my next question, which was what would be the most common cancer? It is ovarian cancer. So it's mainly in females, obviously. And then usually the cancer, in order to cause ascites, has to seed the peritoneum. So therefore, ovarian cancer is very its properties tend to seed the peritoneum and therefore cause the ascites. There are other GI cancers that can do it, but again, they have to be very advanced in order to finally result in ascites. So you can get pancreatic cancer doing it, you can get a hepatoma doing it, or colon cancer doing it, but those are usually have to be very advanced before you start to see the ascites. Ovarian cancer occurs much earlier. It's still a stage 4 cancer, but obviously we unfortunately don't diagnose a lot of ovarian cancers till they're stage 4. So what is this nodule called? It's a nodule in the umbilicus. It's extremely hard on this patient with ascites. It goes along with malignancy.
Gangway lesion. Nodule.
Say it louder.
Janeway nodule.
Janeway nodule. Okay, that I believe is endocarditis.
Uh,
Is it the Sister Mary Joseph nodule?
yeah,
That's a lady's name.
Yeah.
Or something.
Gold
Oh
star.
yeah, Janeway is endocarditis. Yeah.
That's with
It's yeah. Yeah.
I enjoy the zebras, so I like to bring up the obscure stuff. So this is a Sister Mary Joseph nodule. Very good. Described by Sister Mary Joseph, who was first assist to the Dr. Mayo of Mayo Clinic back in the early 1900s. She was noticing all these nodules in patients that had, they were mainly GI cancers, so it was colon cancer, pancreatic cancer, that resulted in these nodules in the umbilicus from metastatic lesions. So this is, again, at a very advanced state of cancer. I have never seen that in my practice personally. So thank goodness it's rare. And I think it's rare because we diagnose cancers at a much earlier stage for the most part before it reaches something like a Sister Mary Joseph nodule. But just something to keep in mind. Heart failure then is number 3 on the list for causes of ascites, and it occurs in about 3% of patients. So again, a small minority of patients with ascites will be due to heart failure. And like I said, it's a sign of very end-stage heart failure. So you won't see it until they're very advanced. And then you have a lot of zebras. Let's see, there's an infectious disease that can cause ascites.
Nephrotic syndrome
Just
or
a,
nephrotic. Just a kidney.
just a psoriasis.
Just
Just a psoriasis.
Goodness, where are y'all coming up with this stuff?
Tuberculosis.
Tuberculosis.
No,
It may occur. I'd have to go look that one up, but tuberculosis is the classic one because it also seeds the peritoneum. So it's that miliary tuberculosis that you can get can seed the pleural lining as well as the peritoneal lining and result in ascites. So you'll see this in developing countries, obviously a lot more than here. But you see tuberculosis as a cause of ascites in about 1% of patients. And then I did hear nephrotic syndrome. That's excellent. That's a zebra. So nephrotic syndrome can definitely cause ascites. So when you have a large amount of protein in the urine, you're getting a low albumin. That causes anasarca, so you're going to get edema everywhere, and you'll get edema into the peritoneal cavity as well. Remember, pancreatitis is a rare cause of ascites, so inflammatory pancreatitis, inflammation from chronic or even really severe acute pancreatitis, a pancreatic pseudocyst, all those things can then create ascites. Budd-Chiari and portal vein thrombosis, so people with very unusual blood clots can result then in ascites due to the blood clots. So that's kind of a comprehensive list. Hypothyroidism also needs to be on this list because myxedema, coma, people with severe hypothyroidism can also then develop ascites.
I did just confirm that the Yale Journal of Biology and Medicine says ascites can be caused by schistosomiasis. Just a brand.
Okay, so I'm going to add that to this slide deck, so I'll be ready for the next time. Thank you very much.
Sure, no problem.
So we'll go from causes to physical exam. So there are 3 maneuvers for ascites on your physical exam. And what are those 3 maneuvers?
Fluid wave?
Fluid wave? Yes. Not first on my list. Hopefully you all are practicing these because it takes a lot of experience before, and I would say I'm still probably about 50 to 60% correct with the physical exam because it's very difficult to find ascites based on your physical exam. But you have to examine a lot of patients. So fluid wave, everybody thinks about that. There's also one right before that on my order of slides anyway.
Heel strike? I don't know. No, that's correct, yeah. Well, okay, I'm not gonna
Yeah,
say it.
percussion called.
Heel strike. Not that it didn't work either.
15 dollars. There you go.
Shifting dullness. So have the patient supine, and then you percuss over the umbilicus, and it should be tympanic. And then as you go to the flanks, you'll have dullness at the flanks, and then you put the patient onto their, in this case, it's the right side, and you repeat the percussion, and they'll be tympanic up toward the left flank and more dull as you get toward the bed there. So as you go downward, so that's shifting dullness based on gravity. Again, a difficult exam to do. You need a lot of experience with percussion in order to do that. Most people will do the fluid wave. How many people does it take? How many examiners does it take to do an appropriate fluid wave?
One.
More than one.
At least one.
Two.
Does it have to be more than one?
So you need 2 because you need a second examiner to put the hand in the middle right over the umbilicus. And then you use the pads of the fingers on your left hand to flick, and you're feeling for that wave with your right hand. So it takes really a third or a second examiner to put that hand in the middle, which gives you a little more accuracy. Again, I'm not saying that this is the most accurate test, and I know, again, students want to just go straight to imaging, but it's good to practice this. There may come a time where we need our physical exam more than we need it now. So I would just always try to be honing your physical exam skills. I do a lot of mission trips too, and where I go, there are no imaging, so you've got to use your physical exam skills. So I think it's still important. The third maneuver is more of a zebra to be complete, not something that you would necessarily do on patients because it requires them to get in kind of a vulnerable position. But the puddle sign is also used, and it's another percussion, but they're on all fours, and you're percussing for the dullness at the bottom of the abdomen, but not something that's necessarily recommended in our politically correct environment. Any questions about all that? All right, so we've done the history. We've done the physical exam. We think they've got ascites. So what is the test we order to confirm our suspicion?
Yeah,
So paracentesis is the next step after the step, because we haven't really diagnosed is there ascites, but yes, once you know there's ascites, you want to do a diagnostic paracentesis. But what do you do to decide if there's ascites or not?
ultrasound.
Yes. So ultrasound is where you would go. And I would always add the Doppler, make sure they Doppel the portal veins to do a vascular study with your ultrasound as well, because you want to rule out that really rare portal vein thrombosis or Budd-Chiari, those blood clots, which can occur that then cause severe ascites. So I usually add a vascular study to the ultrasound. And then after you've established by ultrasound that they do have fluid in the belly, you tap it with a diagnostic paracentesis. So we've got our fluid, but now the lab people are asking you, what kind of tests, doctor, do you want on this fluid? So what tests would we order on the acidic fluid?
Protein.
Good, okay.
LDH.
Protein and LDH. So actually with acidic fluid, protein and LDH are not the most important tests to order. What are you all thinking about? What's the fluid that you would use for total protein and LDH?
Serum protein to fluid comparison. No delicious one. Right?
What fluid would you be ordering a total protein and LDH? You're not wrong in saying it for acidic fluid, but there's a different body fluid that you would order total protein and LDH on because that's Light's criteria.
Is it plural fluid?
Pleural fluid, thank you, yes. So the pleural fluid, you definitely want to have total protein and LDH. Anytime you do a thoracentesis, that's the test you really want to decide transidative versus exudative. Where for acidic fluid, it's not wrong to say that you need a total protein and LDH, but they play minor roles compared to what? What is the major one, the major test you want to get on acidic fluid?
Albumin.
Albumin, very good. So the albumin, a little bit different than the total protein. You have to specifically order albumin because that doesn't really come out on a total protein. So you all have heard of the SAG. What does the SAG stand for? SAG, S-A-A-G.
Serum ascites and albumin gradient.
Correct. Serum to acidic serum to acidic albumin gradient. So what's the cutoff between transidative and exudative on a SAG?
I think it's like 1 or 1.1 or 1.2, something like that.
Correct. So 1.1 is the cutoff. And so which direction is a transidative fluid, greater than 1.1 or less than 1.1? You have two choices. Any courageous volunteers? Because, you know, when I was in your shoes, I would have definitely guessed the wrong one. So you have, is it less than or greater than 1.1 as a transidative fluid?
Less than.
It's actually greater than.
I was gonna say greater than.
Then you'd be right.
Then you do it.
I got it from Liam.
Although there is a situation, we're going to go over all this, but there is a situation where you're actually right. There is one transidative fluid that is less than 1.1, but greater than 1.1, both causes of acidic fluid greater than 1.1 are transidative fluids. There's two fluids that are greater than 1.1, the two of the causes that we talked about. It's either cirrhosis or heart failure for fluid with a SAG greater than 1.1. All the exudative fluids are less than 1.1. I haven't shown this on my screen yet because I was waiting. Other tests that you would run beside the SAG and the protein and the LDH?
Bacterial. Like,
So you would want to do a culture. Usually, again, we talked about tuberculosis, but you would do, yes, you do gram staining culture. We'll talk about that. What else do you get on fluid? Pleural fluid and peritoneal fluid. What other tests do you run besides?
Cell differential.
Yes, so cell count and differential. So you want to definitely get the cell count, know how many white cells, how many red cells. That helps you decide exudative versus transidative as well. Because usually transidative fluids usually don't have much in the way of cells. Where if they've got a lot of cells, they're probably in an exudative state. Why do I have 250 PMNs on there?
Is that a criteria for SBP?
Excellent. Yes. So SBP is 250 PMNs or more. So when you have greater than 250 PMNs, you have SBP, which we have to be specific what that means. It's spontaneous bacterial peritonitis. So that is a patient with cirrhosis of the liver that then develops infection in the acidic fluid that requires antibiotics in order to treat. It usually presents with severe abdominal pain along with ascites in a patient. A lot of times the patient, it's a GI bleeder. So a patient that has variceal bleeds, they can get SBP very easily because again, it's translocation of bacteria between the gut and the acidic fluid, and it seems to predispose when the patient's bleeding. So those kind of go together. So SBP definition is a cell count with 250, greater than 250 PMNs. And then there's the SAG, albumin level, less than or greater than 1.1. Total protein, I put on here, the importance of a total protein differentiates between cirrhosis and heart failure. So once you get a SAG of greater than 1.1, you need that total protein, cutoff being 2.5. And again, this is something that you either have to memorize or look up later. But the total protein comes into play to differentiate cirrhosis from heart failure. So which one is going to be a total protein greater than 2.5? And why?
heart failure, because you're kind of third spacing.
Great job. Yes. So total protein greater than 2.5 should be a heart failure because heart failure does not have a protein problem, correct? Patients with heart failure should have normal proteins. Patients with cirrhosis will not have normal proteins. They have very low proteins because of the lack of synthesis in the liver of protein. So cirrhosis has a double whammy when it comes to ascites because not only are they having pressure problem, right, from portal hypertension, they're also having an oncotic problem because they have very low protein state. So that's why the patients with cirrhosis get such large amounts of ascites. Where again, with heart failure, it's only a pressure problem, and therefore it takes a lot more pressure to cause the ascites. So that's why you only see ascites in end-stage heart failure, and it's really a rare case that I see ascites in heart failure. But I showed it was 3% in that case study that we saw earlier. Glucose and LDH can help you differentiate exudative effusions because the exudative acidic fluids should have a high LDH and a low glucose, just like pleural fluid. You know, you also run a glucose on pleural fluid to decide whether they have an empyema or exudative effusion. And then I can't remember. Yes, we already talked about gram stain and culture. Okay. Does SBP, and when I say SBP, spontaneous bacterial peritonitis, does it have a positive gram stain? So if you see a patient, you do the gram stain, it comes back positive. Can you say, oh, they have spontaneous bacterial peritonitis? Again, I give you these 50-50 questions, so you have at least a 50% chance.
If the gram stain is positive, would you say that's SVP? It's gram stain. Just because it should be. Well, I want to say.
No.
The correct answer. So, as spontaneous bacterial peritonitis related to cirrhosis, there's such a low amount of bacteria in the peritoneal fluid that the gram stain should never be positive. If you have a positive gram stain, what does that mean about your acidic fluid and what's going on with the patient?
Sepsis, yeah, they're really sick.
Correct. And typically, you would never tap a patient with an acute belly. They should have a perforation. The reason their gram stain's positive is because they have a perf of their bowel. And you need to get a general surgeon on the case immediately if you see a gram stain positive in a patient with ascites. The only scenario that I've ever seen this in would be someone that's on high dose steroids. So a rheumatoid arthritis patient that gets high dose steroids, 40 milligrams, 60 milligram prednisone. The surgeons hate that. They hate prednisone because it completely masks an acute belly. So you could get to the point where you tap an acidic fluid in a belly and find out, oh my gosh, they've got positive gram stain. They've got bacteria on culture that is multibacterial culture is growing out, and they need to be evaluated with a laparotomy to find out where the hole is in their bowel. So gram stain positive, you should always be thinking about a surgeon. Other tests that you'd run on the acidic fluid? How about for cancer? If you're thinking the patient has cancer.
You test the fluid for just cancer markers.
I think there are cancer markers that now are coming out for acidic fluid, so that may be something I need to add. I haven't added whether you can do that on the fluid, like for alpha fetoprotein or the CA markers, CA 19.9 or CA 125. But the one I was just thinking about is pathology. So just looking for cancer cells in the acidic fluid, which can be helpful then in patients with ovarian cancer or other cancers. So you could order cytology as well on the acidic fluid. This next slide is a very busy slide from Up to Date on the whole algorithm for someone that you do a diagnostic paracentesis on to show all the different tests that you would run on the acidic fluid, as well as then where you go based on what results you get. And if you're at the top, if you go down the left side of the algorithm, patients have low white blood cell count, so 500 is kind of the cutoff between an exudative effusion and a transudative acidic fluid. And then if their WBC count's under 500, their PMNs are under 250, their SAG is over 1.1, their total protein is less than 2.5. That's, I'm going down the left side there. It's ascites due to cirrhosis. So does that make sense to you all?
Yes.
And then the next one over is heart failure because their total protein is greater than 2.5. So they have all the same numbers except protein is different between heart failure and cirrhosis. And then the next one over is our zebra that I talked about earlier. So when someone said, yes, you can have a transudative fluid that's a SAG less than 1.1, you are correct, because nephrotic syndrome will actually cause a transudative fluid with a low SAG, so the SAG under 1.1. Because it's a low protein state, it causes the serum albumin and the acidic albumin are so close as far as gradient goes that they actually have a low SAG. So nephrotic syndrome is a transudative fluid, but it has a SAG under 1.1. That's the zebra that just is something you need to know if you ever come across somebody with nephrotic syndrome. And then the next one over is SBP, which is spontaneous bacterial peritonitis, because you notice it's confusing because they also cause a perf of the bowel, a secondary bacterial peritonitis. So that could also be labeled SBP. So I have to say spontaneous bacterial peritonitis. The big deal about that to remember is all the other numbers with SBP, spontaneous, looks like cirrhosis. So they have less than 500 WBC. They have but they do have the greater than 250 PMNs. That's the one thing that makes you think, oh, they may have SBP, is the high PMN count. But then their SAG should be greater than 1.1. Their total protein should be less than 2.5. So the rest of their fluid tests should all show transudative fluid. It's just the PMNs that are elevated that then give you the tip off that this is spontaneous bacterial peritonitis. And then if you go on over, you get into the perf bowel along with the other exudative causes, which is pancreatitis, cancer, tuberculosis, and they all can kind of mix together, but usually they have a low SAG with high LDH and low glucose. And then I just added at the bottom for completeness sake some other zebras with Budd-Chiari and portal vein thrombosis. They should look just like cirrhosis and heart failure, but actually they should look just like heart failure, right? Someone with a portal vein thrombosis or Budd-Chiari, the only problem they have is a pressure problem. They don't have a protein problem because it's a blood clot. So they should have a SAG greater than 1.1 and a total protein greater than 2.5. So the Budd-Chiari and portal vein thrombosis can look just like heart failure. Does that make sense?
Yes.
And then myxedema coma, like I talked about earlier, looks just like nephrotic syndrome because it can cause a very low protein state everywhere in the blood, in the acidic fluid. And so it will be a less than 1.1 SAG, but be a transudative fluid. Okay, blow our minds. So we'll go over some cases to try to solidify all this, but it's going to be important. Hopefully you all will get chances when you're on your rotations, especially in the hospital, to see patients with ascites and kind of practice with all this, because it's going to take some time and experience to get to where you understand this. And by me doing these lectures over the years, it's gotten me much more understanding of everything that's gone on before I would have to look all this up, of course. But this is the case that we started at the beginning of the lecture, was the 68-year-old gentleman that presented to your office with abdominal swelling. And he consumes 3 alcoholic beverages a day, has done that for many years, so the possibility of cirrhosis would be there. But he also had a cabbage 8 months ago, so he also has some heart issues. On his exam, he's got a positive fluid wave. He's got dullness to percussion over the flanks with shifting dullness. And he's got 2+ pitting edema in the lower extremities. You do a serum albumin of 3.5. You then do the paracentesis. He's got an acidic fluid albumin of 2.3. So what's his SAG? 3.5 minus 2.3.
0.2.
Yes. I was hoping you all were still on there. I was wondering if I was lagging or something. 1.2. So that is a transidative fluid, right? SAG's greater than 1.1, barely. The total protein is 3.5. So what's your diagnosis?
Heart failure?
Very good. So this was a board question for internal medicine boards. I have to take recertification boards every 10 years, and this question was one of the practice questions for my internal medicine boards. And yeah, you had to know all the way down to the total protein being greater than 2.5 to understand this is not cirrhosis, this is heart failure, because they have a high total protein. So that's very good. And they, in the comments section, he had constrictive pericarditis after his cabbage surgery. So that was the reason for his heart failure and the resultant ascites. Next case. This lady has abdominal fullness, shortness of breath for 3 months. You do the ultrasound and she has ascites. Albumin, serum albumin 1.9, acidic albumin 1.5. So the SAG is what? It's low, it's 0.4. So low SAG, but you're not seeing much in the way of cells. You're not seeing much in the way of high total protein, high LDH. So what's your diagnosis?
SBP.
Problem with SBP is that there's a very low amount of nucleated cells. So the PMNs would not reach greater than 250 because the white cell count is only 140. The other problem is that the SAG is 0.4. So in SBP, the SAG should be above 1.1 because it should look like cirrhosis. But the SAG is low, which makes you think this is an exudative effusion, right? An exudative fluid. But the problem is that there's low cells. So what state has low cells? So it looks like a transidative fluid, except that the SAG is low. So what did we say that causes? It's nephrotic syndrome. So again, the nephrotic syndrome patient is the patient that has a SAG at less than 1.1, but it's still a transidative effusion or transidative fluid. Does that make sense to you all?
Yeah.
The correct answer here would have been severe hypothyroidism, because if you have severe hypothyroidism, you can have the same problem with a low SAG and yet a transidative fluid. Let's go to another one. This gentleman appears jaundiced. And ultrasound shows that he has ascites, and his serum albumin is 2.6, his acidic albumin is 1.1. So your SAG is 1.5, so it's above 1.1. Total protein is 2.1. So what's your diagnosis?
Cirrhosis.
Good. So this is a classic cirrhosis picture, because your SAG is above 1.1, your total protein is under 2.5, and the rest of it is pretty benign, not a lot of nucleated cells. If this patient had a bunch of nucleated cells, so white cells with high number of PMNs, you'd be concerned about SBP. But in this case, the cells are very low, under 250. This gentleman, rheumatoid on prednisone, has severe abdominal pain and tightness of the belly for 3 days. You do the tap on the acidic fluid, and the SAG is 0.7, so under 1.1, with a lot of cells. Total protein 2.8. Glucose is really low at 17. LDH is higher than normal. It's at 350. What's your diagnosis?
SBP.
Which
You'll stick with this.
Maybe septic also.
Yes. So this is not the spontaneous bacterial peritonitis, because this is secondary bacterial peritonitis. So this is due to a bowel perf. This would be the picture of somebody with a bowel perf that you need to get a surgeon involved with right away, because the SAG is low and it's all exudative fluid. And if you did the gram stain in culture in this patient, the gram stain would be positive. And again, you need to get them to a surgeon if you have this scenario. Hopefully for most folks, you're not tapping them, you're getting them directly to the surgeon. Excuse me. This gentleman has abdominal pain along with ascites for the last, the abdominal pain, by the way, is worsened over the last 5 days with history of alcohol dependence. So history of likely cirrhosis. The SAG is 1.3, so it's above the 1.1. There are 450 cells with 80% PMNs. So what's your diagnosis?
SBP.
Yeah.
Let's go. Let's go. It's gonna work.
So this is a classic picture of spontaneous bacterial peritonitis, because again, we're looking at everything looks like cirrhosis with a transidative acidic fluid with a high SAG, greater than 1.1, a low total protein, but then the cells are high. So if you get a high number of PMNs, they'll have, that's the definition, greater than 250 PMNs. So this would be spontaneous bacterial peritonitis. You would treat them with Rocephin, ceftriaxone, is the treatment for SBP. If you have recurrent SBP, you can put them on a fluoroquinolone to prevent recurrent SBP. This lady had 6 weeks, so a 6 week history, so longer history of abdominal fullness and swelling. You tap the fluid and the SAG is 0.6 with a low glucose, high LDH. So you're getting all the picture of an exudative fluid. And what would you think in a 63-year-old female presenting with 6 weeks of this?
Ovarian cancer.
Yes, very good. So this would be a sign of cancer, most likely. Very concerning. You'd want to do cytology on the fluid and do further testing to clarify that. But this would be kind of the picture of malignancy. Okay, just finishing up, I wanted to go over quickly the treatment of ascites in patients with cirrhosis. So what treatments would you, once you've got the patient diagnosed, now you need to treat them, what things would you treat the patient with for ascites?
Therapeutic thoracentesis, and depending on how much fluid is lost, give them more albumin.
Good. So what's the cutoff for how much fluid you can take off before you have to add albumin?
5 liters.
5 liters?
That's what we did in the hospital.
That's exactly right.
Good job,
Josh,
I was
oh, yes.
Not good.
when I
Not
looked it up, it did say 5 liters. So that sounds like a whole bunch of fluid before you'd start adding back albumin, but that's true. So that is like third on the list. So if you haven't done the first 2 things, or the first 2 things fail, then you go to therapeutic paracentesis for sure, and draw off fluid from patients, and that will help to treat the ascites. But what other things can you do before the therapeutic paracentesis?
Diuretics.
Yes. So which diuretics do you use in ascites?
Spironolactone.
Yes, spironolactone has actually now become probably more important than the loop diuretic as far as what at least they're talking about for being helpful in ascites and also helping with the overall pathophysiology with cirrhosis. So spironolactone is very important to get patients on if they have ascites, along with Lasix. Why is it called Lasix?
Last 6 hours.
You guys are all over this. All I have to do is just stare me in the face for 15 minutes before I finally give them the answer. So it is last 6 hours, Lasix. Good. So usually a loop diuretic with spironolactone. Make sure you check a kidney function within a week of starting diuretics in patients with cirrhosis, because you don't want to drive them into hepatorenal syndrome. So you got to be very careful, because most of these patients are going to be vascularly dry to begin with, right? They're very tenuous. They usually have low blood pressures. They don't like a lot of fluid shifts. And if you give them a large amount of diuretic, you're going to throw them into hepatorenal syndrome. So I would check a BMP within a week of starting any diuretic. I'd start with 20 of furosemide. I'd start with 25 of spironolactone, and then just slowly increase over time, because you don't want to throw these patients into kidney failure, which is very hard to resolve. And the nephrologists do not like to see patients with cirrhosis in their nephrology clinic. The first thing to do is just to counsel patients on sodium restriction. I don't know if you all have tried a 2 gram a day sodium diet, but it is horrible. Heart failure patients also need to be on sodium restriction too, but very difficult to achieve. The average American diet is 8 to 10 grams a day. So 2 grams is extreme restriction, but that will help reduce ascites if you can get patients to sodium restrict. They also can fluid restrict, especially if they become hyponatremic. So low sodiums, or yeah, low serum sodiums, you would also talk about fluid restriction. Then the diuretics, then the therapeutic paracentesis. 5 liters is the cutoff before you have to add albumin. And then there's one more thing. So what happens if you're doing therapeutic paracentesis on a weekly basis on a patient and they're pretty tired of being stuck all the time? What can you do after therapeutic paracentesis before transplant? This is not transplant talk.
Tips.
TIPS. What does TIPS stand for?
Yeah.
Shunt. So it's a shunt between the hepatic vein and the portal vein. So it pretty much shunts past the liver in order to reduce the ascites, and it's fairly effective at doing that. So TIPS procedure, what's the big complication of a TIPS procedure? It's one of the patients with cirrhosis complications that occurs. It's going to make that complication a lot worse when you bypass the liver.
Hepatic encephalopathy.
Yeah.
Good. So hepatic encephalopathy. So you have to really guard against that in post TIPS procedure. I've had several patients where what's the treatment for hepatic encephalopathy?
Lactulose.
Good, yes. So usually I have to increase their lactulose or rifaximin. Rifaximin is kind of the second line after lactulose. Rifaximin can be extremely expensive and hard to get a hold of. But if they fail lactulose, you can also add rifaximin. How many bowel movements do you want a patient with cirrhosis to have in a day to clear their ammonia?
2.
At least 2 to 3. You don't want them to have 5 because then you're going to be hepatorenal. You know, you can dry them out from so much diarrhea. You don't want to have 1 because that tends to build up more ammonia. So the usual, you want to ask patients in clinic how many bowel movements is a good thing to ask patients, and you want them between 2 and 3 a day in order to clear their ammonia. And I would push that if they've just had a TIPS procedure. We usually give them more of either the lactulose or the rifaximin to help to clear more ammonia, since that tends to be a really big complication. Any questions that you all have? That's all I had today. Hopefully this
Slides.
yeah.
Yeah,
This-
that's perfect. Thank you.
Available to the students if they wanted to review like the cases or things like that.
What'd you say, Dr. Moore?
I just was hoping that they'd have access to the slide deck to be able to go over these cases later.
Oh, yeah. Yeah. You sent those to me, so I'll send them out.
Okay, I appreciate it. Well, thank you all very much.
Thank you so much.
Thank you so much for presenting today.
No problem. Have a good day.